going for the exams. Thank you for giving me this opportunity to present this topic and also research methodology. The question is that of November, the practice question is November 2023, question 11. So next slide, so that I can read the question. I'm not seeing it completely. Okay, can you just bring it down small? Okay, you are a physician in a state with documented increase in the incidence, morbidity, and mortality of colorectal cancer. Patients are complaining of abdominal discomfort following colonoscopy. There is a new test, fecal immunohistochemical test, which can help to diagnose colorectal carcinoma. You are asked to carry out a study to determine the diagnostic utility of FIT. I'll be using FIT in subsequent description, please. In diagnosing colorectal cancer, what will be A, the title of the research, B, main aim and specific objectives of this research, C, 4 research questions, D, 2 key focal areas of literature review, E, components of methodology, F, study design, G, what are the statistical tools you will use in data analysis? How would you present your findings to the medical director? Answer to question A. The title of the research, the study will be determining the diagnostic utility of fecal immunohistochemistry test in colorectal cancer. B, my main aim, the aim is to assess the diagnostic accuracy and clinical utility of fecal immunohistochemistry test as a screening tool for colorectal cancer. Specific objectives, to determine the sensitivity and the specificity of the FIT in detecting colorectal cancer compared with colonoscopy. 2, to determine the superiority of FIT against colonoscopy in terms of early detection and accuracy. 3, to determine the cost effectiveness of FIT test in detecting precancerous lesions and prevention. Next slide. Research questions. Next slide, please. What is the first question? The answer, the question is 4 research question 1. The first one is, what is the sensitivity and specificity of FIT in detecting colorectal cancer? And how is it compared to the available standard screening methods, colonoscopy in this case? What are the rates of false positive and false negative results in fecal immunohistochemistry testing? 3, how does fecal immunohistochemistry testing vary across different stages of colorectal cancer screening? And can the test reliably identify early stage of colorectal cancer compared to advanced stage colorectal cancer? 4, to what extent does fecal immunohistochemistry testing contribute to the cost effectiveness of colorectal cancer screening programs? Next slide. Next slide, please. Areas of literature review will be review literature on colorectal cancers and screening methods available with researches on their sensitivity and specificity. Review existing literature on fecal immunohistochemistry test as a screening test compared with the available standards, their performance in other parts of the world, advantages and its limitations. Next slide. Components of the methodology will include study location here, location, identify and give a brief description of the target location where the study is going to be conducted. Study population, a brief description of the target population and from where they will be recruited, including their demographic features. Obtain informed consent from all participants or assent from their proxies, clearly explaining the study objectives, procedures involved, potential risks and benefits. Next slide. Inclusion criteria and exclusion criteria, study design, study period, sample size determination, all are components of this research methodology. Next slide. Study protocol. Collect baseline information, including demographic details, medical history, family history of colorectal cancer, and any previous colorectal cancer screening history. Administer fecal immunohistochemistry tests to all participants in the study. Ensure the collection of multiple samples per participant to enhance the reliability of the result. Schedule colonoscopies for all participants as the reference standard for comparison. Ensure that the colonoscopies are performed by experienced gastroenterologists in the presence of the investigator. Next slide, please. Sampling technique, such as simple random sampling method, could be part of the component of the research methodology. Study materials, equipment, and reagents. Data management and statistical analysis. Ethical consideration. The study design here is a cross-sectional study. Each participant will receive colonoscopy and fecal immunohistochemistry testing, the two tests, and the results of both tests compared and accuracy status, they will be determined. The statistical tools, there are many, but I just try to group them into this. Use descriptive statistical tools like mean, median, standard deviation, and frequency distributions to summarize and describe the characteristics of the study population, including demographic data, test results, clinical outcomes. The diagnostic accuracy of fecal immunohistochemistry testing can be determined calculating sensitivity, specificity, positive predictive values, and negative predictive values, using colonoscopy result as a reference standard. These measures will assess how well the fecal immunohistochemistry testing performs in comparison to the reference standard, that's colonoscopy. Next slide. Survival analysis using Kaplan-Meier curves or cross-proportional hazard to analyze time to event outcomes. Utilize the statistical methods such as logistic regression to assess the association between the fecal immunohistochemistry result and colorectal cancer outcome after adjustment for potential confounding factors such as age, gender, other risk factors. Next slide. Then if you have a continuous outcome variable and want to adjust for baseline differences between groups, analysis or covariance, ANCOVA may also be appropriate. Perform subgroup analysis by stratifying the analysis based on variables such as age, gender, and risk factors to assess whether the diagnostic performance of fecal immunohistochemistry complex test varies across different population subgroups and risk factors. Comparing means between groups by using chi-square. Use this test to compare proportion between FIT and colonoscopy groups for categorical outcomes such as the detection rate of colorectal cancer or the adherence or compliance rate. Use this t-test if the outcome is continuous and normally distributed. A t-test can be used to compare means between the two groups. That's it. Then how to present the study to the CMD. Presentation will be in the form of an abstract under the following subheadings, followed by recommendation based on the outcome of the study. Background and purpose. Here, concise information on colorectal cancer, need for accurate diagnosis, screening methods, and their limitations will be emphasized. And also state the purpose of the study. The methods should highlight the study design, duration of the study, total number of participants recruited and excluded, study area, study population with demographic factors relevant to the study, such as age, sex, distribution, and other risk factors that will be identified during the course of the study. Next slide. Then the results should display the summary of key findings such as sensitivity, specificity, positive and negative predictive values, and overall accuracy to compare the diagnostic accuracy of fecal immunohistochemistry test and colonoscopy. And then we give a conclusion, summarize the key findings with the implication to clinical practice significance in improving colorectal cancer screening. Then the recommendation. Recommendation like integration of fecal immunohistochemistry test.
Okay, Chief, you have 1 more minute.
Okay, integration of fecal immunohistochemistry test into the hospital colorectal cancer screening programs, either as a replacement or adjunct to colonoscopy, will depend on the outcome of the study. In any case, one of the recommendations should emphasize the implication of the study finding for clinical practice, future research, and improvement in screening subjects. Thank you. This one is just an overview. The subsequent slide is just limitation of this and fecal immunohistochemistry testing and then its advantages. Thank you.
All right. Thank you so much, Dr. Musa, for that beautiful presentation. Very lucid. Okay, so now we'll take comments and questions from the participants first, and then our teachers. And please, let's keep the thanks coming on the chat. Let's keep the thanks coming on the chat. Thank you for that lucid presentation. Okay, so I don't know if we have any comments or questions for the presenter. Okay, let me I'll just, okay, Dr. Muhammadu Sani, please go ahead.
Okay, thank you very much. Thank you very much for that presentation, Dr. Gazama. Sir, can you go to the first slide? The first, the option A, the answer to option A. Hello?
Hello?
Yes, the title of the research. Now, I wanted to say, is it going to be determining the diagnostic utility of fecal immunohistochemistry tests in colorectal cancer or clinical utility? I'm a bit confused at this juncture. Should it be diagnostic or clinical utility?
Determining the diagnostic clinical utility. Determine the clinical utility of fecal immunohistochemistry tests in colorectal cancer.
Because my just concern is, if you look at the objectives, they are trying to compare colonoscopy with FIT. But if you look at the title of research, it's limited only to diagnosis using the FIT. So I just wanted us to seek advantages or the. Hello, sir.
I'm hearing you.
Yes, sir. So I wanted to say, can we make it a determining the
diagnostic accuracy
and determining clinical relevance and diagnostic utility or advantage of fecal immunohistochemistry in diagnosis of colorectal cancer? Because the topic must be encompassing, so that if you're expanding your objectives, they will capture that key things, because you are trying to show the role of FIT above or in relation to colonoscopy. That is just my concern.
Okay, noted.
All right, thank you so much. Okay, maybe later our teachers will also react to that. Okay, Dr. Sori, please go ahead.
Yes, good morning, everyone, and thank you for the presentation. I also have a concern with the statistical methods. If you can go to the statistical methods, because you mentioned that you'll be doing a cross-sectional, the study will be a cross-sectional design. But then in the statistical method, you're talking about assessing outcome variables using Kaplan-Meier logistic regressions to assess the outcome of patients. With the design of a cross-sectional study, will you be able to do such, and will you have the information to do such analysis?
All right, thank you. Dr. Musa, do you want to react to that?
Actually, I just mentioned, I just mentioned some of these statistical tools, not bearing in mind the study I was performing, because it just list the statistical tools. So I would have just listed them like that without explaining them. So probably I'm sorry about that. I didn't take that into consideration, honestly. I just mentioned listed the statistical tools. In fact, it was yesterday that I decided to explain some of these things. Otherwise, I only listed them without even explaining any of them. Though the statistical tools that will be required definitely would depend on the study design, just as you have emphasized.
Okay, I was thinking the question is list the statistical tools you use for your study. So I don't know, I was thinking just like, sorry, should it be cross-sectional? Shouldn't it be like a prospective study or maybe a paired study design where you maybe have to use like a 2x2 continuous table and chi-square? Okay, just thinking aloud. Okay, maybe our teachers also react to that. Oh, Dr. Sorry, do you have like an idea what it should be?
Yeah, like you rightly mentioned, if you want to assess outcome, then you have to have a follow-up period. If you're doing a small study in a small center, you can just do a simple cohort study. Take a cohort of patients and you follow them over a period of time so that you can be able to assess outcome. But if you're just doing a cross-sectional study, then all the statistical methods you use is just to compare how the test performed compared to the gold standard in this case, which is the colonoscopy. You won't be able to assess outcomes. If you want to assess outcomes, then the methodology would have to change. Thank you.
Thank you so much, Dr. Sorry. Okay, let me go to the chats. Okay, so there's a lot of thanks for you, Dr. Musa, for the presentation. Dr. Olaiton says, thanks for the lucid presentation. Dr. Amadi Ilomba, thank you for the wonderful presentation. Dr. Araga says, thank you for the presentation. Dr. Blessing Azukoy Amadi, thanking you. Dr. Anthony Abo, Dr. Itohan, Dr. Adipimpe, Dr. Afolabi Michael. Then Dr. Olaiton is talking about, she's asking a question. You talked about assent. Is it a common condition in children? That we need to add assent form. Okay, so that question is to you, Dr. Musa.
What? Okay. No,
Did you get the question?
I heard the question. You said assent. Do I need to add assent to the consent? Hello?
No, she's saying you talked about assent, and she's asking why are you talking about assent? Is it as a common condition in children? Why do you need the assent form?
No, for one reason or the other, probably the subject may not be able may not, like in some cultures, probably to take a decision about health intervention, they may say the husband or the relatives or this thing should decide for them. So you don't call it consent any longer, you call it assent. That's my understanding. You get consent from the subject himself or herself, but if it's a relation or proxy, you call it assent.
All right.
Sorry.
Okay, so Dr.
This is hello. Sorry to about this, please. Consent is what you get for getting the procedure done. Now, consent is usually given for somebody that has reached a legal age to be able to give consent, which in our environment is 18 years. Okay. Now, it is possible for someone over 18 years to give somebody the power of attorney to take consent for them. Okay, so for instance, someone can be 18 and say, no, let my father be the one to decide. So that person gives consent. Now, assent is what you get if the person you're doing the procedure on is not the one to give consent. Okay, so somebody below the age of 18 or at least over the age of, okay, it's the person to have agreement. Okay, I give you permission to go ahead and do the procedure. It's more like just agreeing to cooperate with the procedure. But consent is the written document, informed consent. It's written to all the parties or the hospital the opportunity to do whatever they want to do. Okay, so please, that's different. Assent is usually given and you are not the one giving the consent. Go ahead with the procedure given by the person that you do the procedure on. Consent and completely, but there's always has to be consent. Assent is just means the person is not the one giving the consent, so the person is just agreeing to commit to allow you to do the procedure on the person. Okay. Yeah. Thank you.
Thank you. Thank you so much, sir. Okay, thank you so much, sir. Okay, let me just take the last comment on the chat before I come to you, Dr. Godia. Okay, so Dr. Olalekan is also sharing the same concern as Dr. Sori. Thank you for the wonderful presentation. What statistical tool did you use to answer each of the specific objectives? Can you explain why you chose the cross-sectional study design? Okay, I think he has talked about that, and our teachers will add more to it. Then I also have this thoughts. I don't know, for the title, I was thinking, would it be okay to add the study area to the title, maybe like in Ogun State, or I mean the area where you're doing the study? Okay, so that's my concern. Okay, Dr. Godia, go ahead.
Yeah, good morning all. Thank you so much for the presentation. I just want to say something regarding the assets. So this has to do with the inclusion criteria. You know, there are some cancer syndrome that occur in children, like familial adenomatous polyp, all these Cowden syndrome, and the rest of them, plus Jagger. Screening is indicated in children in age from 10 years above. So if we are looking at this group of patients as the inclusion criteria, we can add assent into the inclusion criteria, because this group of people will not be able to give consent by themselves. Thank you.
Thank you so much for that addition. Thank you, sir. Okay, so we don't have more comments, and I can't see any other hands raised. So, Ma, please, I'll hand over to you. Do we have comments from our teachers? Dr. Christabel, Ma.
Oh, thank you. Thank you, Dr. Ekele. I want to appreciate the presenter. I think that was a fair attempt. This is his first presentation and it was quite fair. Thank you so much. Thank you. Chief Chitu, sir, any comment? Chief Chitu, Dr. Fatima will come in later.
Sorry, I wasn't I didn't really follow the presentation like that, but I want to be sure that among the instruments he said he was going to use, did he mention the ROC curve?
Presenter, did you mention the ROC curve?
Hello?
We
Because
can hear you, sir.
if it's discovering sensitivity and specificity, we need the ROC curve. Did you come across that? That is like the most important.
Sorry, sir. Yes, I came
tool
across it, but
if you're
honestly,
going to...
I didn't. Sorry, I saw it, but I didn't include it on the slide, sir.
That's the most important thing. In fact, if everything else, all the other chi-square and all the rest are not important. If your main objective is to see whether that particular test can be a screening tool for colorectal cancers, then that is like the most important thing. To know the sensitivity and the specificity, you need to draw the ROC.
Okay, sir. Noted, sir. Thank you.
Yeah, so please include that in your slide. And for everyone, that's the most important statistical tool here. Yeah. All right, thank you, Dr. Christabel.
Oh, thank you, sir. Thank you. I think that's about that. At the end of the discussion, we'll call in Dr. Fatima. Dr. Ekele.
Okay, can we go ahead?
Yes,
next
we can.
question.
Yes,
Okay.
we can.
All right.
So,
Thank you
presenter,
so
thank
much.
you so much. We appreciate you. Thank you.
Thank you so
Sorry,
much, Ma.
Dr.
Thank you, sir. Dr. Shitu. Thank you, Dr. Musa. Okay, so we'll go on to the next question. Dr. Opute. Please, can you share your screen? Okay, she's here. Please, can you share your screen?
Yeah, I'm trying to do that. Good morning, everyone. Can you see my screen?
I can't see it.
You can tell me. Can you see my screen now?
I can see it now, but okay, go to the presentation.
Can you see my screen now?
Yes, I can see it.
Okay.
Can put it on slideshow.
Mhm. How do I do that?
Can you put it on slideshow? Is it possible? Okay. Okay, that's good. Please go to the next slide. Okay, leave it here. All right. Good morning, our facilitators and colleagues. Dr. Opute, we're taking question 1. Practice question 1A. Okay, Dr. Opute, you have the floor. You have 10 minutes.
Okay. Good morning, professors, consultants, and my fellow specialty registrars. I'll be taking the practice question 1A. A 52-year-old man with hepatitis C infection, alpha-1 antitrypsin deficiency, and liver cirrhosis, who is being worked up for liver transplantation, is asthmatic, obese, and anxious of the outcome of the procedure. The post-liver transplantation BP was 80/60, and he had 8 units of packed cell transfused, subsequently became breathless, autopnic with bilateral leg swelling. The echo done showed ballooning of the cardiac apex, sparing the base and posterior wall of the heart. The question was, what is the diagnosis? Some candidates were asked, what is a syndrome describing this condition called? B, what is the pathophysiology of the heart failure? C, how would you manage? And D, what is the prognosis of the diagnosis? So depending, if the question was, what is the syndrome? It would be takosubo syndrome or the apical balloon syndrome. If the question was the diagnosis, it would be biventricular heart failure secondary to
So the accreditation is today. It's today now. No wonder
Sorry, Dr.
No,
I can't hear you, Dr.
you don't have time.
Can you meet your mic?
They told you guys. Oh.
Hello, Dr. Augustine.
Okay. So if the question was what is the syndrome, it's going to be takosubo syndrome. If the question was what's the diagnosis, then the biventricular heart failure secondary to takosubo cardiomyopathy in cardiogenic shock. The big part was what is the pathophysiology of the heart failure? Pathophysiology remains unknown and poorly understood, but several theories were proposed. So it could be as a result of catecholamine-mediated myocardial stoning, which due to the stress induced, because this condition is actually stress-induced, catecholamine is released, which would cause toxicity to stoning of the myocardium. Now, the apical portion of the left ventricle have the highest concentration of sympathetic innervation found in the heart, and this may explain why the high catecholamine concentrations seem to selectively affect its function. So there could be hypokinetic or akinetic left ventricular APS, and also left ventricular outflow tract obstruction. Another is the heart failure could result from the left ventricular systolic dysfunction and left ventricular outflow tract obstruction. And this is because the base of the heart actually contains the beta-adrenergic receptors, which could explain this. Other proposed mechanism could be the multivessel epicardial coronary artery spasm, coronary microvascular dysfunction, myocarditis, and ACS with reperfusion. So the C is how will you manage? So for these patients, one is multidisciplinary, admits the patient to the ICU, nursing cardiac position, use the ABCD of resuscitation, where provide supplemental oxygen and cardiac monitoring, supportive treatments, which could lead to spontaneous rapid recovery in nearly all patients. Then manage as having ACS. Manage as having ACS until proven otherwise. Okay. So this patient is in cardiogenic shock. So the priority here is actually to manage there should be top priority in managing this. So low dose diuretics can be given. Ionodrops can come into play. Fluids can also be given, but however, you need to be cautious, and the central venous pressure has to be monitored. For this particular patient, when the systolic BP is now greater than 90, other medications can come into place where the patient will benefit from beta blockers, the ACE, but bearing in mind this patient is asthmatic, so the cardioselective beta blockers would come into play. Then heparin or enoxaparin, morphine, and clopidogrel. And also, so the investigation ECG would show the low amplitude transient ST elevation and T-wave infarction in the precordial leads, V2, V3 with QT prolongation. This usually occur over 2 to 3 days. Chest radiograph could be normal or could show pulmonary edema. Bedside echo, whole motion abnormality at the mid and apex and ballooning. Then the cardiac biomarkers levels, there may be a small rise. BNP might be elevated. If just to add to the management, because of the left ventricular outflow tract obstruction, patients will benefit from intra-aortic balloon. Okay. Then coronary angiography would show non-obstructive coronary arteries. The prognosis in takosubo is typically excellent, with nearly 95% of patients experiencing complete recovery within 4 to 8 weeks. Or however, in this patient, the prognosis is poor due to the age and the fact that this patient has other comorbidities. The complications occur in 20% of cases, particularly in the early stage, and include left heart failure with or without pulmonary edema, cardiogenic shock, left ventricular outflow obstruction, mitral regurgitation, and could even result to death. So by way of just like a write-up, takosubo cardiomyopathy, also known as the stress cardiomyopathy or broken heart syndrome, is a sudden transient cardiac syndrome that involves dramatic left ventricular apical akinesis and mimics acute coronary syndrome. The modified Mayo Clinic criteria for diagnosis requires the presence of all 4 of the following. So you could one, transient hypokinesis, dyskinesis, or akinesis of the left ventricular segment with or without apical involvement. 2, the absence of obstructive coronary disease or angiography, evidence of acute plaque rupture. 3, new ECG abnormalities, either the ST segment elevation or T-wave infarction. And 4, the absence of pheochromocytoma or myocarditis. The risk factors would be any stress related events, maybe learning the fact that patient just got the news of a death of a loved one, bad financial news, legal problems, natural disasters, could be anything really. Use of withdrawal from illicit drugs. The history, patients could present in chest pain, dyspnea, palpitation, nausea, vomiting, syncope, cardiogenic shock, cardiac arrests. Unlike preceding emotional or physical stressful trigger events occurring approximately 2/3 of patients. Unlike the ACS, for which the peak occurrence is during the morning hours, takosubo cardiomyopathy events are most prevalent in the afternoon, where stressful triggers are more likely to take place. Well, it could be anytime really. On examination findings, usually non-specific and often normal, but the patient may exhibit the clinical appearance of ACS or acute congestive heart failure. Patients may appear anxious and diaphoretic. Could have tachycardic arrhythmias or bradycardic arrhythmias have also been reported. Hypotension can occur from a reduction in stroke volume, and murmurs and rays may be present. The differentials for these could be ACS, angina pectoris, aortic dissection, cardiac tamponade, cardiogenic shock, cooking-related. Then you have the coronary artery vasospasm, dilated cardiomyopathy, and open. Thank you.
Thank you so much, Dr. Pute, for that beautiful presentation. Okay, so now we'll take comments and questions from the participants first. And please, let's keep the things coming on the chat. Thank you for the presentation. Okay, so, okay, so for now, we don't have any comments on the chat yet. So let's take comments from the participants. Dr. Ibinabo Amakri, please go ahead, you have the floor.
Okay, good morning, teachers and our colleagues. Thank you, Dr. Pute, for your presentation. From the question, this patient is hepatitis C virus positive with liver cirrhosis. I think part of your investigations will include the viral load and also the DNA, and also your management should include treatment of hepatitis C virus and also a multidisciplinary management, including the gastroenterologist. Thank you.
Oh, thank you so much, Dr. Amakri, for that addition. I was wondering if you should also include the pulmonologist in the multidisciplinary team because of the asthma. All right, Dr. Sori, you have the floor.
Yes, thank you very much.
Yeah,
for a very good presentation. Just a few comments. In addition to the investigations, the coronary angiogram has to be done for this patient, okay, because that's how you confirm the diagnosis. Like she rightly mentioned, it can mimic acute coronary syndrome, all the findings. So until you do the angiogram and then you see that the coronaries are clean, there's no problem with the coronary, that's the time you confirm the diagnosis of takosubo. So part of the investigation, the patient has to have a coronary angiogram done. The management, go to the slide where you talk about managing the shock, because the patient was, the BP was low, obviously. Now, managing shock in patients with takosubo cardiomyopathy is different from the usual management of cardiogenic shock. Okay. Giving inotrope is actually contraindicated, can worsen the condition of the patient. Any form of inotrope is contraindicated in takosubo cardiomyopathy because of the pathophysiology of the condition. You know, there is apical ballooning, but however, the basal part of the heart is still contractile and functional. So if you give inotrope to such patients, the basal part will be contracting while the apical part would not be responding at all to the inotrope. So you worsen the left ventricular outflow tract obstruction. Okay, so in fact, if the patient comes in with shock and you have not with shock and ECG findings suggestive of myocardial infarction, okay, and you've not yet have the chance to do an echo, and you are managing the shock, you give inotrope, the blood pressure dips, that should raise your suspicion that this patient may have takosubo cardiomyopathy. So if you're sure about the diagnosis from the onset, you don't give inotropes at all. So what you use in patients with takosubo cardiomyopathy are pressor agents. So pressor agents that do not have, you know, inotropic effect on the heart. So one example of such is phenylephrine is what you can use to help improve the blood pressure. And if the phenylephrine does not give you enough blood pressure control, like you mentioned, then you can employ other other interventions like using an intra-aortic balloon pump to be able to maintain the blood pressure in this patient. And then all the other medications that you listen, because in your approach, managing the shock should come first. Okay, you manage the shock, and then when the patient has recovered, that's the time you want to bring your beta blockers, ARBs, into the mix. Okay, thank you.
Thank you so much, Dr. Sori. Please, Dr. Kalamama, you have the floor.
Okay, thank you so much, the presenter, for a lucid presentation. Okay, mine is just a few add-ons. You did very well. I don't know if you can take me back to the chest radiograph finding, because I saw somewhere like it's going to be normal when you do a chest radiograph. Okay, so basically, as you met, okay, yeah. Okay, so let me just go straight to the point. Okay, because what I saw there was that it's going to be a normal finding on chest. It's a normal or pulmonary edema. We all know that the problem is coming from the apex, where we have ballooning of the apex, the left ventricular apical aspect of the heart. And you earlier mentioned that it's because the catecholamine receptors are found more there. And you know, this is actually as a result of stress, emotional problems, and all, where catecholamines are actually released, and then it goes there to bind. And then there's a form of exaggeration at that particular apical area where you have more of the receptors. So what I'm trying to say is that on chest radiograph, what you're going to see, you're still going to see that ballooning of the left ventricle. That's the apical aspect of the left ventricle that you also see on chest radiograph. Then also other features suggestive of heart failure. So that's what you actually use to say, okay, this patient actually has takosubo cardiomyopathy using the chest radiograph finding. So you will see that ballooning of the apex, that's the left ventricular apical region, be ballooned out. Then secondly, just to add on to what you said, you made mention of ACS, that's acute coronary syndrome. Okay, so how that actually comes about is that apical aspect of the left ventricle is ballooned out. We all know that those epicardial vessels actually traverse through the myocardium. So at that apical area, what happens is that there's impingement of the apical vessels. So what happens is that it's stenosed, not like it's a pathologic stenosis, but it's as a result of impingement of the apical vessels traversing through that apical area of the left ventricle. So that's why sometimes when you do an ECG or you do maybe troponin I, you will notice that they have some form of left ventricular ischemia due to the impingement of the apical vessels traversing through the apical area of the left ventricle. Then also another pathophysiology to that of presenting with ACS is we all know that they have problems with the outflow tract. there's reduced stroke volume or cardiac output due to the obstruction of the left ventricular outflow tract. So what happens is that the heart doesn't, the heart actually needs about 25% of blood that gets out of the heart, the myocardium. So what happens is that the myocardium doesn't get up to that 20% of blood it needs. So it presents with that ischemic feature. There's kind of some form of hypoperfusion that can result. So that's the pathophysiology of the ACS behind takosubo cardiomyopathy. So that's just what I have to say to add on to your presentation. So you did a wonderful job. Thank you so much.
Okay, well, thank you so much, Dr. Kalamama, for that add-on. Okay, I don't know, I just have some concerns, especially for the cardiologist. So if the condition actually presents like ACS, but it's not really an ACS, so you manage as ACS, there's actually no coronary artery stenosis, even if it seems like so. Why do you manage as ACS? And then, Dr. Putin, in your criteria, you mentioned that you have to rule out few chromocytoma. How do you do that? Is it just clinically, or you have to actually do plasma metanephrines? And then, sorry, you were talking about the management of the shock. So how, from the patient's presentation, how do you make up your mind that this is actually takosubo cardiomyopathy and not from any other cause? Thank you so much.
Okay, thank you. I think the cardiologist, thank you for your great input, which is duly noted and appreciated. I think from the question, the ECG, the echo findings actually gave this away, but the ballooning, the apical ballooning, so from the onset, from the on-go, diagnosis of the takosubo was already in place. However, if this patient had come in, maybe a bedside echo could not be done, or the diagnosis is still pinging between ACS or any of the differentials, then I think the right thing to do is to manage as ACS until proven otherwise, where the good standard coronary angiography comes into place, which would show the non-obstructive coronary arteries. Then I think you mentioned about the Mayo criteria for pheochromocytoma. I mean, pheochromocytoma has to do with catecholamines. There's a surge of catecholamines, which takosubo 2 does the same. So I would believe doing the either plasma or urinary metanephrines might come into place here. I stand to be corrected. I can't remember the other thing you asked.
Thank you, Raj. You've addressed my my concerns.
Okay,
all right, thank you so much. Okay, so let's go to the chats. Let's go to the chats before we take more comments. Okay. So Dr. Olaiton is saying thank you for the presentation. Dr. Ifomide is saying thank you. Dr. Abimbola is also saying, why do you combine aspirin and clopidogrel?
Okay, I think the management for ACS has to do with dual antiplatelets. So you either give the aspirin and the clopidogrel, or aspirin, prasugrel, and the others, but it has to do with dual antiplatelets.
All right, thank you. Dr. Rita Wakaba is saying thank you. Dr. Becky saying well done, Dr. Buti. Dr. Justice Ibiti saying thanks for the presentation, Chief. Dr. Anthony Abos thanking you. Dr. Mamodo, thanks so much, Mia. Dr. Rita Lacos says thank you for the presentation. Dr. Mamodo is saying, is there a reason why it's commoner in post-menopausal women? Is estrogen protective? Can we give ionotropes in the basal or focal variants? Okay, go ahead.
Okay, thank you so much, Mamodo. I think going through the literatures, I didn't come across anything like about why the menopausal, in terms of the menopausal or post-menopausal women, if anyone in the house can help with that, that will be duly appreciated. Thank you.
Okay.
I think
Maybe Kadela just okay, go ahead.
okay,
Go
okay,
ahead.
let me just come in here. You know, generally, following delivery, you know, it comes with so much emotional stress, it comes with so much physical stress. So I think that stress, the stressor aspect of the post-menopausal aspect is what brings about that. You understand? So the stressor, so you know, catecholamines are actually released during stress. So what I'm thinking is as a result of the stress following the delivery. So that's what brings about that. So those catecholamines are actually released, and then it goes to the apical area, and then binds there, and then brings about the takosubo. So I'm thinking about the stressor aspect following delivery. So that's why it's actually commoner with them.
I thought you
Then
said
that's what I thought. Then
post-menopausal.
Sorry, not postpartum rather.
Dr. Florence,
I
you're talking
correct
about
myself.
young women.
Sorry, I didn't get it. What did you say? That's postpartum. Sorry, I said postmenopause. Postpartum is what I'm talking about. The stress that comes with it. Then there was also something related with prolactin as well. Prolactin also there's some form of relationship with prolactin with the stressors. So those are different theories that have actually been stipulated as regards that. So the stressor from the stressor hormones during the postpartum, and then also from prolactin as well. Thank you.
Okay, so thank you, Dr. Florence, just giving us the aspect on postpartum. Maybe someone else comments on postmenopausal.
Yes, hello.
Okay, go ahead.
Hello.
Go ahead, Dr. Sorry.
Yes, thank you, Florence. I think the prolactin aspect comes in more with peripartum cardiomyopathy. So with this takosubo, like the question says, more common. It's seen commonly in postmenopausal women. Okay, so even though not directly, but you know that in the reproductive age group, because of the hormones that women produce, those hormones have some protective effect on the myocardium. Okay, so when they get into the post menopausal stage, they of course lose that protection of the reproductive hormones, and therefore they become more prone to the damaging effect of high catecholamine level. Okay, and therefore we see more this phenomenon of takosubo cardiomyopathy in women in the postmenopausal stage. So it's just massive secretion of catecholamine due to stress, whether it's emotional, physical stress, or whatever. And because now in the postmenopausal period, they've lost that protective effect of the reproductive hormones, then they become more prone to developing the cardiomyopathy. Let me just mention about the concern raised in managing the patient as acute coronary syndrome. Okay, so the scenario that was given, this is a patient that was already in hospital, you know, has undergone a procedure and then went into shock. So they did an echocardiogram to find out what is causing the shock. And they were able to see the features that were suggestive of takosubo cardiomyopathy. So mostly the out-of-hospital presentation is usually typical of an ST segment elevation myocardial infarction. So they'll come with chest pain, you know, difficult breathing, you know, and then you do an ECG in the air, which is what we do for a person that presents with chest pain. You see ST elevation, typical of acute myocardial infarction. And in the management of such patients, you actually you don't wait for troponin or echocardiography. Once you see ST elevation time, you need to intervene quickly. If you have the facility, you take the patient to cath lab. If you do not have the facility for cath lab, you want to thrombolyze. You know, doing an echo must not delay your management in patient with an ST segment elevation myocardial infarction. So that is why the mantra is to manage STEMI until proven otherwise. So that when you take to the cath lab, you see that the vessels are fine, then you can now just manage as you takosubo. So sometimes you have to even withdraw the dual antiplatelets, you know, and then manage the patient based on their presentation. I must mention also that when they present in that acute setting, you definitely have to manage as acute myocardial infarction. No two ways about that. And also, some forms of acute myocardial infarction, especially infarction affecting the left anterior descending artery, okay, resulting from the left anterior descending artery, can actually present with apical aneurysm, you know, and it looks like takosubo cardiomyopathy, but it's actually an ACS, coronary stenosis, artery stenosis. So you have to, and even like I pointed out in the definition, it is there that, you know, you get those findings and you confirm that the coronaries are clean. So you have to go to that, you have to manage as ACS until angiography shows you that the coronaries are clean. Then you consider it to be a takosubo cardiomyopathy. Thank you.
Yeah, thank you so much, Dr.
Thank you so much, Dr. Sori. Please, I think the next question is also for you, Dr. Sori. Dr. Mamodu's second question is also for you. He says,
what was it about?
Can we give ionotropes in the basal or focal variants? You know, you were talking about not giving ionotropes.
Okay, not giving anything there. So you don't give it because, you know, the myocardium is not going to respond as a unit. Okay, certain areas will not be contracting. So even without the apical variant, you know, when you give ionotrope, even in the non-apical variant, you get desynchrony. When you get a desynchronous contraction, and it will not improve your EF. So basically what you do when they're going to shock is to give pressor agent to improve the blood pressure. And if the pressor agents are not helping you to get adequate blood pressure, then you have to go in for your intra-aortic balloon pump to be able to maintain and to get the patient out of the shock.
Okay, thank you so much. Okay, so let me just take the remaining comments on the chat before we go on to our teachers. Okay, so Dr. Temilade Adeyanju is saying, thank you for the lucid presentation. Please kindly note that the emotional stressor for takosubo can also be extremely good news and extreme excitement. Thank you so much, Dr. Temilade. Dr. Rita Omaka, thank you for the lucid contribution. Dr. Kalamama. Dr. Anthony Aboy is saying, what makes it takosubo, please, from the history given? Okay, I think she has addressed that. She talked about that. Okay, then Dr. Mosope says, well done, Dr. Opute. Lovely presentation, thanks. It's good to note that NT-proBNP is remarkably higher than troponin in takosubo with or without heart failure. Hence, it raises its suspicion. Other things that increase suspicion are female gender, QTC prolongation. Also, there are forms of takosubo cardiomyopathy, typical or classical, mid-ventricular, and basal. Well done. Thank you so much, Dr. Mosope, for that contribution. Dr. Opute, you may want to add this to your slides. Okay, so yes, the theory of protection of estrogen has been explored too. Okay, and Dr. Mahmoud is saying, thanks so much, Drs. Conte and Florence. Okay, so that's it for the chat.
Yeah, thank you so much for the. Yeah, thank you so much for the contributions. I would want to appreciate my teachers and also contributors from Florence and Ibinabo and and the others. Thank you so much. Thank you.
All right. Thank you so much, Dr. Pute. Thank you so much, everyone who contributed. Okay, so now I'll hand over to our teachers, Dr. Christabel.
Yes, Dr. Ekele, thank you so much. I most appreciate the speaker, Dr. Mia. Thank you. Dr. Pute, thank you so much for presentation. And I appreciate Dr. Kalamama, Dr. Conte for their comments. Thank you so much. Thank you. They elaborated on some key areas. Thank you. Those that asked questions, thanks. Those that commented, thank you. I don't know if any of our facilitators, Dr. Fatima, in-house cardiologist, do you have any comments on this particular one before we call you for the first presentation later?
Yeah, well done to both. Can you hear me? Hello. Hello.
We can hear you. Go ahead. We can hear you.
Okay. Yeah, well done to both presenters. I think as far as general medicine is concerned, there is no much to add. Dr. Conte and Florence have given enough differentials and reasons for the treatment. So as per general medicine, this is enough. Well done.
Okay, thank you. I thought as much too. They're quite elaborate with their contributions, and I must appreciate them. I don't know. I was just wondering if these little cardiologists that we have, I think some of them made some comments on in the chat box, but we have a lot of cardiologists in the house. I think they are the largest in the group. But once again, I must appreciate
a lot of them are making very valid comments on the chat. And of course, Dr. Conte and Dr. Kalamama, they are the group rep of the cardiology team. So probably that's why they speak up. But most of them make comments on the chat.
Thank you. We need them to speak up. That's one of the comments I wanted to make. When you speak frequently, it shows. Just note the way Dr. Kalamama speaks. She's quite eloquent. She's quite fluid with her speech. She's good. It shows that she speaks often. Dr. Conte, same thing. Dr. Kele, Dr. Kopi, Dr. Fatima, Dr. Mamudu. When you hear people that speak often, I know even the way I speak, this wasn't how I was speaking when I started my presentation. But the more you speak, better you become. That's why we ask our participants, please speak up. Don't wait for your class rep. Don't wait for Dr. Kalamama to always be the one speaking. Yes, Dr. Kalamama added this, but I also want to add this. This is a very interesting topic. We want to encourage this whole thing, not to we appreciate the cardiologists, but we want people to be speaking up. We want people to be speaking up. Conte, Kalamama, Mamudu, the same people, people are coming up and we really appreciate that. All we're saying is that we want more people to be speaking. Please, this is the speaking exam, because one thing we will always say is once you go for this exam, if you have been talking, by the time, because the time is like a sixth sense kind of thing. You understand? It's not something that, okay, you might plan it to your mind, though, but what is coming out from your mouth might be something entirely different. But if you're used to speaking on the spot, you're always putting on the spot, you're always speaking, you find that you'll be so fluid. And it will just occur naturally, and when you are speaking like examiners without nodding, wow, this is good. Even if you are making sense, you're not making sense, you're nodding their head. So please, we want to encourage everyone to speak up. We appreciate the Cardiologist Forum for their active participation. I know Dr. Kopi always come to your defense. We appreciate that too. But please, we want to hear more of your voices, please. The cardiologists, the nephrologists, the gastroenterologists, the dermatologists, all of you, all subspecialties, please. If they're taking your question, please come out your numbers. Let's know that, wow, we have cardiologists in the house. So that's just what I want to emphasize. But overall, it was a wonderful presentation, wonderful comment from the Cardiologist Forum. So thank you. Dr. Fatima, thank you so much. I don't know, Chief Cookie, any comments, please? Okay. There's no comment. Okay, yes.